the foot. Whew, it's a lot, y'all. So we just went over the failing, the toes, which is the little purple guys. Now the foot is further divided into the tarsals and, I'm sorry, the tarsals and the metatarsals. So if you would think about the palm and how your carpal bones, well, now these are called tarsal bones, and the palm bones were your metacarpals. These are now the metatarsals. All right, so we're going to have to learn about the toe bones. So these are the metatarsals 1 through 5. And then these are the tarsals. We'll get to the actual names of those little guys here in a second. So we already went over the interphalangeal joints, the joints of the metatarsals. I only highlighted that the base of the third metatarsal, or the third metatarsal joint, is important because it is the centering point or the central array location for a lot of the projections of the foot. Okay, the third, so on your hand, 1, 2, 3, you're looking at number 3. All right. So we are also going to go over the little sesamoid bones. Those are going to be discussed in mini number 9, I believe. Oh, yeah, it says so right there. Mini number 9, because I like the sesamoid bones. I'm going to went over the whole thing because there's different x-rays for those. So this is just a lateral view of the foot. And here's our tarsals. So how they want you to remember it, you can make up your own mnemonic however you would like. But if you start from the back and work your way forward, you have come to Colorado next Christmases. Okay, these are the 3 cuneiforms. So let's go. This backbone here is the calcaneus. This bone, this entire bone right here, is the talus. Here is the cuboid. This is the navicular. Excuse me. And then we have the 3 cuneiforms. Okay, we have the, can you guess? Proximal, intermediate, and distal cuneiform. First, second, third cuneiform, however you want to remember it. Some of these bones also have older names. The calcaneus bone is known as the os calcis or the ox calcae. The talus bone is called the astragalus, and the navicular bone is sometimes called the scaphoid. But since there's a scaphoid in your wrist, they figured to leave the navicular down in your foot, and that way there's two different ones. Let's see. There's only 7 tarsal bones in the foot as opposed to 8 carpal bones in the wrist. All of the tarsal bones are referred to as ankle bones. However, it is only the talus that is directly involved in the ankle joint, and we'll show you that. So the calcaneus is the largest and the strongest foot in the bone. It's probably important. The largest and strongest foot of the bone. So the posterior portion is often called the heel bone. The most posterior inferior part of the calcaneus contains a process called the tuberosity. The tuberosity can be a common site for bone spurs, which are sharp little outgrowths of bone. But I will tell you this, it's not the bone spurs that cause the pain. You can have pain and not have bone spurs, and you can have bone spurs and not have pain. So it's actually a part of a tendon that is the plantar fasciitis that is being upset there. Another ridge in bone that we're going to look at is the perineal trochlea and the sustentaculum tali, which is the support for the talus. So here we are looking at the superior surface of the calcaneus. Okay, here is the medial process and here is the lateral process. This would be like if you were looking down directly at your foot and looking at the calcaneus from the top down. So here we have the anterior surface, the middle surface, the sustentaculum tali. That is actually the bony part that sticks out of your foot that you can feel on the medial side of your foot. We have the lateral process, the posterior articular process. Here's the perineal trochlea and the calcaneal sulcus. That just means the little groove that the calcaneus goes into. I'm not going to ask you questions over any of that. What I am going to need you to know is these bones right here. So this is looking at the lateral foot, like we were looking at it this way. So this is, I know this is the fifth, the base of the fifth, right? This is the cuboid, and these are the cuneiforms. This right here is the navicular. The dome is the talus bone. This whole bone right here is the talus bone. Here's your calcaneus, and this is the talocalcaneal joint. That just tells you where it is. I'm not going to ask you about any of this. This is just so you know where these articulate. So again, oh yeah, right. Here's the cuneiforms. We have medial, intermediate, and lateral. I think I said proximal and distal. I was wrong. So here is the medial, intermediate, and lateral cuneiforms. We have the cuboid, the navicular, the talus, and the calcaneus. Come to Colorado next 3 Christmases. I'm not going to ask you about the arches, but it is good to know that your foot has an arch medially, it has an arch along the lateral side, and then it has a transverse arch. So whenever somebody says that your foot have flat arches, that can actually mean several different things. Or that you have a flat foot, that doesn't necessarily mean that your foot is flat. So getting into the foot projections, the normal routine projections are a PA, oblique, and a lateral. 40 inches. So the KVP range is going to be about 55 to 65. Now the easiest way to do a foot x-ray is to have them on a table or a stretcher, bend their foot up, and put that foot onto the IR plate. Use a sandbag to prevent the IR plate from slipping all over the place. Sometimes you can have them cross their legs and to put the knee down for some support. So with the foot, we're supposed to angle 10 degrees towards the heel to be perpendicular with the metatarsals. And the CR is directed to the base of the third metatarsal. You remember I said that? Base of the third metatarsal. I'll show you the evaluation criteria. How about that? So here is the picture of the foot x-ray with a 10-degree angulation towards the heel. And here is the evaluation. So feet and toes should be hung with the toes pointing up. Okay, this is how it is to be presented for the radiologist to look at. So here we go. We have the cuboid bone, right? The navicular. Then we have 1, 2, 3 cuneiforms. This is the joints. These little guys are the sesamoid bones. And yeah, it does get hard to see because this looks very nice, and then your bones start to get thicker right here in the foot simply because they're holding up so much more weight. Okay. Um, the physicians can window it and can try and look in there to see uh, all the structures. So here's a medial oblique. You can have your patient turn their foot to the inwards, and if you look at your sponge, it's making it a 45-degree oblique. Um, Sometimes it's not even necessary. Sometimes patients can do that on their own. I will tell you, though, however, to remember to have them do their whole foot and not just part of their foot, because you will foreshorten the bones in the foot if you don't. Where's the video? If you don't do it to the whole foot and they only do like part of the foot, like their toes or something, you're going to get a crappy image. So just be aware of that before you even shoot the image. So I wanted to point out right here that the KBP range is a little bit more. It's 60 to 70. We upped the KB because our foot was flat, and then we went like this, which therefore made our part thicker, right? It made it just a little bit thicker with the bones coming up this way to be an oblique, and our foot bones are the thickest bones of our body. Well, no, they're very weight bearing bones of our body, and they start to get thick right there underneath the ankle. So that's why the KVP range increased. The CR goes into the base of the third metatarsal, like we had said, and we generally want the foot rotated to place the plantar surface 30 to 40 degrees to the plane of the IR. And remember when we were talking about 30 to 40 degrees, here's your IR, here is me, this is 180 degrees, this is 90, halfway between 90 and 180 is 45. So right about here is 40, right? You just keep cutting the halves. I'll show you the anatomy demonstrated. So here is the special sticky little widget. I need to see everything from the toes all the way down past the calcaneus. I do not want to see images where this foot is cut off, because that is not a foot image. That's a toes. If we don't see everything that we need to see on the x-rays, you didn't do it properly. So also remember too that if your patient can't turn their foot, you can turn the tube in the IR plate. You can turn to somebody who's laying in bed. You can make this happen, okay? So here's a lateral oblique. This would be if you had the patient turn their foot outwards. It's not routinely done, and that's why I'm like, you can actually see when you mess up or when the patient turns it the wrong way. And sometimes we do actually do it if the physician wants to open up that joint space of the navicular right there, but not really, because you see how all the bones are stacked on top of each other when the other medial, and now I can't get back to it, when the other medial splayed them open to make them very nice and pretty. Okay. So I will remind you, on a lateral, it is good practice. Put your hand, and please put on gloves, but you need to put your hand on on the bottom of their foot. You need to start feeling how their foot will ride and how the arches of a foot will not make it lateral unless you put your hand on it and line it up. Okay, once you start doing a foot, you'll understand what I'm talking about. But sometimes these folks, They may need a washcloth underneath their toes of their feet because they sag, okay? And that is not lateral. We need them as lateral as possible. So, for instance, if I had, somebody's foot and I just needed to shove something up underneath them to make it straight as opposed to sagging, you see where I'm getting at here? We have to be aware of that. Start feeling of people's feet with gloves on because people are gross. Just so that you can feel how an instep feels. And then you'll begin to feel how it feels when you can see that the foot rides like this or they're going like this. Sometimes, and I'll tell you right now, you will have to put a washcloth folded over underneath the ankle. Or if you have a bigger person, you will have to get something bigger and fold it and put it underneath their knee perhaps, or however you have to do it to make the whole foot and ankle into an alignment, because people can have different sized legs, and if the tibia and the fibula are like this, you're going to get foreshortened, and if they're like this, it's going to be elongated. You want to line them up, make it even, so that there's no foreshortening, okay? The technical factors is 60 to 70. Don't over rotate the foot. Um, that was for a lateral oblique. So I'm going to stop you right here. This image came out of the book and I already don't like this image. This foot, this foot x-ray should be 90 degrees from the tibia like this, and I believe if it's an example that's in the book, it should probably look right, but I digress. Anyways, that's why I put this ankle bone, or the tib fib, should go right here. All right, that's how I know it's straight. This actually looks very straight. Here's the base of the fifth metatarsal, here's the cuboid, the calcaneus, the navicular. This dome one is the talus, and there's your cuneiforms, okay? So remember when I was saying like you gotta have the foot lined up well enough? This is if you were doing it from the lateral to the medial, and you can see how rounded the side of the foot actually is. That's just the way people are, okay? Your foot rounds off to the edge. So this is an alternative image in case you couldn't do it the other way. It's not going to be as straight, but you can still get what you needed to get, but you're going to have to make sure that that foot is as straight as possible.